All right, guys, we're going to kick this off. Okay. All right. Good morning and welcome to the Georgetown University McCourt School of Public Policy. My name is Stacy Pogue. I'm a senior research fellow with the Center on Health Insurance Reforms. I wear a couple of hats here, and one of them is heading up some of our healthcare transparency work. For those of you that are not familiar with our center, we are a team of national experts on health coverage and health care, and we study the interplay of federal and state policy and how it affects people, how people afford and access healthcare services. We put out a bunch of research briefs and reports, and we also provide technical assistance to federal and state officials, as well as other healthcare stakeholders. We are very excited to have you at this event. It's part of a series of events looking at the affordability of healthcare and of private health insurance coverage. Private health insurance coverage forms the backbone of coverage in the United States, but the high and rising prices paid through private health insurance to consolidated hospital systems and other providers makes health coverage and health care less and less affordable to consumers and employers alike. In this event series, we're going to look at issues of affordability and policy options that can help ensure we maintain access to affordable and high quality health care. And today specifically, as you know, we're going to talk about transparency. We're going to hear from folks who are leveraging the transparency that exists today to increase affordability, from consumers, employers, researchers, state officials, about what is needed next out of Congress and the administration. I particularly want to thank the sponsors for today's event, Arnold Ventures, for their commitment to improving affordability of health insurance coverage and health care. There are a few issues more challenging and complex than healthcare costs, and they've taken it head on. Real quick, I want to note some logistics. This event is being recorded, and we will post the recording to our website afterwards and email you a link. And we're going to have an incredible panel, and you will get to ask them questions. So get those ready, and then when it's time, just raise your hand, and we'll run a microphone over to you. Okay, first up, though, I have the pleasure of introducing Corey Enslin, who will give some opening remarks. He's a senior policy advisor to the Health Subcommittee of the House Energy and Commerce Committee, and in that role helped lead the work on the Lower Cost, More Transparency Act, passed by the House of Representatives at the end of last year with broad bipartisan support. And as you probably all know, that bill contains many policies to increase affordability and increases transparency throughout the healthcare system. So please join me in welcoming Corey.
Thank you, Stacy, and everyone at Georgetown for having me. This is an awesome event on a topic that's near and dear to our hearts at ENC. I have to give my legally required caveats that I'm speaking for myself, not the committee in an off-the-record capacity, but I'm really excited for this and looking forward to the great panel we have today of some of just my favorite people in this space. I'll just start to say why we in Congress care so much about price transparency. Members go home, they hear from patients about a system that is increasingly complex, increasingly opaque. They get hit with bills that are idiosyncratic, and they pay too much. They don't know how to navigate the system, and for their trouble, they get hit with bills that they don't understand and can't afford. So a lot of that is really underpinning why I think we have seen such a big bipartisan push in this space. And we all know the statistics, right? The United States government pays more as a percentage of our economy for healthcare than virtually any other developed nation, and significantly more at that. And the consequences of that are somewhat obvious, right? We pay too much for healthcare. But there are also trade-offs that, to me, are less tangible, right? What productive capacity could we have in our economy if employers and families and governments were able to spend a little bit less on healthcare? And I think that's a very difficult question, but this is why you've seen such bipartisan interest in making the system a little more simple, a little more fair, and hopefully a little more affordable. So a little bit of background on how we got here from a policy perspective. So I think a lot of folks in this room probably know this, so I'll be brief, but the ACA included perfunctory language requiring price transparency from hospitals and insurance companies. And then the Trump administration built off of these with regulatory actions that have really laid the groundwork for the price and insurance, the price transparency rules for hospitals and insurance companies we have today. And the Biden administration has iterated on these and improved upon these and increased enforcement of these, but we still have a long way to go. So basically where we are now is hospitals are required to post their negotiated rates with insurers, and they either have to also post a file with 300 shoppable services and the price is paid for those that is consumer facing, or have a self-service tool that patients can use to pull up the prices they're going to pay. Insurance companies, it's a little more complicated. They're required to post a big machine readable file of all their rates. They are required to post another big file of all their allowed amounts and out of network payments. And they are supposed to post a file with historical net drug prices and rates for drugs. This has not been implemented yet, despite a lot of urging from both Ranking Member Pallone and my boss, Chair Rogers. We've seen nods in this direction from the administration, but this is still outstanding. So far, these rules have had, I think, a tangible impact. We just saw a report, I think, a few weeks ago from the Turquoise Health Group. They're a transparency vendor out of California that works with this data. And some of the preliminary findings were extremely encouraging, in my opinion. So the thing I would highlight is in the top quartile of prices, you saw the largest price decreases across the board. So in the top quartile of prices for NICU, down 18%, or 8%, I'm sorry. Radiology, 8%, labs, 6 to 7%. And generally speaking, you see good price sort of looking convergence. And this is despite the fact that we have a long way to go in making this data more usable and more actionable, that I'm sure you're going to hear from people who are far more eloquent than me about exactly how to do that. But you're already seeing positive steps. But that is why we, at the Energy and Commerce Committee, kicked off a bipartisan process at the beginning of last year to try to really get at some of these issues. And we heard from experts, patient groups, stakeholders, some of which I think may be in this room right now. And I think we had a very comprehensive bipartisan process along with other committees in the House and produced what became the Lower Cost, More Transparency Act. And what this did was it both codified the rules, but also tried to improve upon them, tried to increase enforcement to make sure that hospitals are actually posting the files, but also increasing the quality of the data with more audits than you get today. And I actually just saw before I came up here a report from Patient Rights Advocate that found compliance as they measure it with the hospital price transparency rule has gone down significantly over the last year from where it was, which just underpins the reasons as to why we need to do some of these things and show a more concerted whole of government effort to improve upon those rules. It would also codify the drug price transparency rule that has not yet gone into effect. And I think that would be extremely important because despite the fact that this rule has been on the books since, I think, 2019, it hasn't gone anywhere yet. And I think there's a lot of member interest. We'll watch any Energy and Commerce Committee hearing to really get at the black box of drug prices. And that would be a great way, first step to do it is enforcement of that rule. Now, throughout our process, we also heard not just about transparency, but also about competition and really making sure that there are competitive effects in the marketplace. And in the Lower Cost, More Transparency Act, there are provisions that reflect that. The most meaningful of which I think is probably the down payment on Medicare site neutral payments that the bill includes, which would apply to outpatient prescription drugs under Medicare Part B. But there are also more modest proposals in there that relate to reporting in Medicare Advantage about vertical integration and also just requiring CMS to consider the effects their actions might have on consolidation generally. Things that will modestly move the needle, hopefully in the right direction of a more pro-competitive regulatory regime. So bottom line, really good bill in our opinion. Obviously, we're biased, but members of Congress seem to agree with us. We had 320 votes on the floor of the House of Representatives in a broad bipartisan vote, and I can't, in my time up here, think of any major healthcare reform standalone vote in the House that got such bipartisan support, which I think is really impressive. And that's a great start. And I think that bipartisan support from in the House, but also from both the Trump and Biden administrations portends good things for price transparency moving forward, right? I don't think the issue is going away. I have no crystal ball or unique insights as to what might happen between now and the end of the year legislatively. But as staff, we will be ready with a hopefully good package if the moment is ready to strike. But regardless, I think conversations like this are incredibly important to have to make sure legislators grasp the urgency of the moment and aren't hearing just from folks like myself, but also the immense brain power in this room as to why this issue is so important. And I'm really thankful that folks like yourselves are keeping the drumbeat going, and looking forward to continuing to work together on all that.
That's awesome. Thank you so much, Corey. I'm going to take just a few minutes to level set on healthcare transparency and then hand it off to our incredible panel. Interest in transparency reflects growing concern about high healthcare prices that's diminishing affordability. How do I make this work? Brilliant. All right. So more than 40% of adults with employer-sponsored insurance report that they have difficulty affording their health care, and nearly 30% say that they've delayed or skipped needed health care due to costs. Prices in the commercial market are a particular challenge. The prices that private health insurers and group health plans pay to providers are much higher on average and have been growing much faster than prices paid in our public health insurance programs. Spending on healthcare is a function of both prices and utilization. And as economists will tell you, it is growth in prices more so than spending. Sorry, guys. I messed that one up. I think I need a, there we go. It is prices more than utilization that is driving increased spending in employer-sponsored insurance and our premiums. As this report, the most recent report from the Healthcare Cost Institute shown, repeats again. So transparency is crucial. You've already heard that. It's needed by consumers who shoulder increasing out-of-pocket costs. It's needed by employers who sponsor the health plans that cover half of Americans, but they often don't know if they're getting good value. They both need price information. They also need quality information. But that alone isn't expected to bend the cost curve very much. Evidence from efforts to give consumers more information on prices to make them better shoppers shows that it has pretty minimal impact on spending. And the CBO looked at all the available evidence and concluded that transparency focused on consumers and employers is going to have a relatively weak cost containment tool capable of moving prices, reducing commercial prices up to about 1%. But it's important nonetheless, and transparency doesn't need to stop there. First, transparency can include more than prices, and we'll talk about that. And it can work through broader mechanisms than individual consumer employer decisions as well. For example, it can be leveraged by policymakers or regulators so that they can better target their policy solutions or their actions around affordability. Price transparency is also crucial because, as you know, it's a fundamental requirement for a competitive market. But in many cases, it might be necessary but not alone sufficient, particularly in really consolidated markets. 90% of our hospital markets are highly consolidated. In those cases, transparency might be insufficient alone to really increase the competition the way we would like. All right. Transparency has momentum because it enjoys broad bipartisan support. You can't read those words, but what it says is that 95% of Americans said they wanted this Congress to make healthcare prices more transparent, right? And as Corey already mentioned, it enjoys broad bipartisan support. That is true at policymakers at the federal level and the state level. Yet expanding transparency can still be a battle. And that's because when information is revealing, there will be stakeholders that would rather keep it under wraps. For example, at the same time we see growing information that the types of entities that own a provider can influence both cost and quality, we see some notable pushback on efforts to increase ownership transparency. All right, real quick, the kind of buckets of transparency ideas that are included in the Lower Cost Transparency Act. There are many areas of healthcare where transparency is needed, right? Price transparency and the pieces in the bill Corey covered. We have rules in place now, and providers and payers and hospitals are posting prices, consumer-friendly prices, and machine-readable files. The idea behind the machine-readable files is that it would give researchers and analysts and app developers ready access to the raw data so that they can translate it into actionable information that the rest of us can use. We're a few years down the road. There are many steps forward. We have massive amounts of new data available, but the big picture vision of those rules isn't fully realized yet. The GAO just put out a report last month, and they looked specifically at the hospital transparency pieces. But in my opinion, their big picture takeaway could apply equally to both the hospital and the payer data. And it's that the data are still hard to use, and that we don't have large scale systematic use of these data yet. But one group that is able to get them and use them is commercial data vendors. We've seen several come into the market that specialize in ingesting and parsing these gigantic data sets. But they reportedly charge hefty fees and can place limits on how the data can be shared. So we know that they're available to well-resourced stakeholders. So that could be private equity companies, that could be large hospitals and health systems, even large payers. But today, not everybody, not the rest of us don't have ready access to like findings and information from the data widely yet. But the lower cost, more transparency would codify the rules. It would build on them, as Corey said. And I think it's important because it continues this iterative process of making the data easier to get, easier to use, and better able to inform cost containment efforts. There's a blog on the Cheer, there's a post on the Cheer blog with more information on that point. Ownership transparencies, next up there, it's definitely part of the conversation. It's the state and federal level, because lawmakers and regulators that want information on their own markets and consolidation in their own markets need some really basic information on who owns and controls the healthcare providers. And that is sometimes really hard to get. The House examined broad provisions, but the piece they rolled up, and Corey mentioned in there, requires Medicare Advantage plans to report on the providers that they own. There's also billing location transparency in the bill. Current billing practices make it hard actually to tell the brick and mortar location of where hospital outpatient care is delivered. It could be in the hospital, it could be off the campus in a clinic far away. But there's a provision in the bill that would require off-campus hospital outpatient departments to get a unique NPI, a billing identifier number, and use it when they're billing Medicare. And that gives Medicare some more context than we have today on where outpatient services are actually being provided. And the last two I'll just mention because I'm turning it over to the panel. There's a focus, of course, on PBM transparency and some additional steps to help self-insured employers understand the fees that they are charged and access get access to their own claims data. And now, this is the part that that I'm excited about. I'm going to introduce today's panel. I think it's a superstar panel. It is moderated by Reed Abelson of the New York Times, and I'm sure everyone in here is familiar with her work at the intersection of healthcare and business. You have read her reporting on pharmacy benefit managers and the giant health conglomerates that are gobbling up provider practices. And you know that what she does really well is explain the incentives that drive the behavior of the payers and the providers, and then what that means for all the rest of us. We also have 4 expert panelists. Dr. G. Bai from the Johns Hopkins Business School and School of Public Health, Gloria Sachdev, CEO of the Employers Forum of Indiana, Amy Tuarson, who's the Executive Director of the National Academy for State Health Policy, and Anthony Wright, the new Executive Director of Families USA. Their full bios are in your brochure. So I'm not going to read them to you, but I'm going to just introduce them by saying they are experts and they are in the trenches pushing for more transparency and affordability and leveraging the transparency that exists today. And so they know the benefits of the information that's available today, and they know the limits, and they know what Congress needs to do next and the administration needs to do next. And that's where the rest of us come in. So why don't you join me in welcoming our awesome panel. You guys come on up and I will turn it over to Reed.
On. So what I thought I'd do is start with some questions for each panelist, and then we'll talk a little bit, and then we'll open it up to questions. I think the first thing I would be interested is on the states and what they're. Yep, you're up first. You know, we've heard a bit about what federal lawmakers are thinking about. I'm interested in what you're seeing in terms of transparency efforts in the
Yeah, no. Good morning, everyone. It's great to be here and on this fantastic panel. Thank you to Georgetown for really highlighting this topic. So I'm Hamie Tawarson. I'm from Nashville. Just so you know, I work with all 50 states across the country. We're a nonpartisan nonprofit organization who really works to help states innovate and develop and implement new policy ideas. So that's where my comments are coming from. We are well invested in this topic. We have a Center for Drug Pricing and a Center for Health System Reform. We've had that for many years. And so we are really, I think, in the trenches, so to speak, working with states. So I'll just share a couple of things. So thank you for that fantastic overview. It really set the stage well. So prior to 2020, there was a number of states that implemented consumer-facing transparency tools, about a third of the states across the country. So I like to think states are the laboratory of democracies. They have ideas, they try them, some work, some don't, but it actually really helps at the federal level to see and take a look at what's been happening at the state level and to help inform what can happen at the federal level. I will say, just honestly and anecdotally, those tools were not really widely taken up by people in the states where they were implemented. And some of the evidence showed that it didn't have a very significant impact on lowering prices, as you heard in the overview. So really where we are now is consumers are asking state legislators, governors who we work with, insurance commissioners, please do something to lower drug prices and our insurance premiums and our out-of-pocket costs. It's not affordable. And so where we are working with states are what are the drivers of those costs and how do we understand more about the market? So I'll just mention a few things if that's okay, Reed. In the drug pricing space, we know right now they haven't implemented at the federal level drug pricing pieces, but states have been doing a lot of work. We've been tracking drug pricing transparency laws and working with states on these laws since 2017. And I'll just do a couple stats for you. Since 2017, there's 24 states that have enacted 38 laws requiring prescription drug supply chains to report information on drug prices. That's half the country. And they are different types of requirements. They're manufacturer requirements that they have to report price increases and launch prices for new drugs above certain thresholds. There are wholesaler requirements where they have to report on costs and volume. And health plans have to report on the most frequently prescribed and most costly drugs covered. So just a couple of examples. And really, I think states feel like that's the first step to understanding the black box of prescription drug pricing and then what policies can follow. You really have to start to understand where we are in the supply chain and where the costs are really at causing the most challenges. There's also 19 states that have enacted PBMs to report information on drug coverage, utilization, rebates, and other benefit management information. And there are a number of states that have passed a lot of PBM reform bills, and we continue to think that that will happen in 2025. So very active at the state level there. A number of the states are trying to make all of this information public. It's hard for consumers to understand all of these different pieces. So though they're trying to make it public, I guess I would say my opinion is, will it have an impact at the consumer level? I don't know. Will it have an impact on the policy level? I think yes. I also want to just talk about health system cost transparency. So that has been very challenging. And really, I think, so I've been a state law person for a long time. I was a health lawyer years past. And a health system today is not a health system that existed 20 years ago. They're very complicated. There are a lot of different business structures involved, really hard to understand where are all the costs and how do we think about why they're driving and continuing to increase price. So I would say a couple things. States have been working on all payer claims databases. They are trying to improve those. You know, they can't require those self-insured plans to contribute their information on the commercial market, so they're not always complete. But there are 18 states right now that have APCDs, and they're really trying to leverage that data to understand what are we paying across the system so that we can understand how to negotiate better prices. I'd say share two other examples, cost growth benchmarks. So there are 8 states across the country that really have tried to identify where are we spending in the aggregate and how do we understand the drivers of those costs. And so those, I will just say those are predominantly in blue states. That has not expanded to red and purple states as much. But I think it's a starting point to have a conversation around what is the aggregate spend, both on the health system side and the pharmacy side, so then we can then understand what policies can flow from that. This is another topic I just want to mention where we're spending a lot of time is understanding consolidation and private equity. So I think we all, this room is very well informed. Consolidation is really reducing competition. So the ability to truly negotiate lower prices is more and more challenging as we have a more consolidated market. And private equity has entered into that equation and made it, all the more complicated to understand some of these pieces. So we are spending a lot of time talking to states about how do we peel the onion to really understand what is happening with respect to health systems, to understand when a state tries to go in and say, let's negotiate, let's, think about how to lower costs. And, hospitals come back and say, well, I'm going to have to close my doors, or I'm not able to really meet my margins. How do you even negotiate from that if you don't understand what's happening within that health system? So I would just say there's a number of states that have passed legislation to require the reporting of mergers and acquisitions that are happening. They're reporting to the Attorney General's office. Indiana's a state. Gloria can talk about that. And then there are a couple of states that have gone out even beyond that, and that's Oregon, Massachusetts, and California, who've really taken some steps to try to have more market oversight. That's not going to be the path for all states, and we're not promoting it as a path for all states, but it's examples of how certain states are trying to take action. Oregon, I would say, is probably the most aggressive, perhaps, state out there. They have the authority to do analysis of the proposed transactions, and they can administratively approve, deny, or condition a transaction. So they actually have that power. Massachusetts and California have affordability offices that can make recommendations to the state AG to legally contest the mergers or acquisitions. So, and these are covering a lot of different types of entities, including PBMs, health systems, private equity coming into the market. And then the last thing I would just say is there's also the piece on ownership. There is a number of states that are requiring reporting of ownership. I would say Massachusetts probably has the most complete database of ownership, and it's reported as a condition of licensure to their Department of Health. And I think that's a piece of the puzzle as well that extends also to things like nursing homes, where we know there's another driver of cost and condition of quality. So maybe I'll stop there for now, Reed, if that sounds good, and we can talk more about all those things.
Yeah, exactly. So actually, I'm going to then, I think, turn to Gloria to ask about employers, because we're talking about private insurance, and it's been generally the employers who theoretically are responsible for all of this. And so I'm curious your view of what employers have done to take advantage of the transparency efforts, and also, quite frankly, what they haven't. Yes.
The opportunities for improvement. Thank you so much. It's a pleasure to be here today. I'm Gloria Sachs. I'm President and CEO of the Employers Forum of Indiana, and we are kind of boots on the ground trying to figure this out. What we have done with transparency. So our journey started, 2016. We had employers that were in different markets, and they could see that in Indiana, their prices were higher than in Michigan or in other states, but they had at a very top level, nothing granular. They would say, my overall ED visits are $800 more expensive in Indiana than they are. So very top line numbers that they could see from their aggregated claims data. So we started down a journey of price transparency, partnering with Rand Corporation, and have done a series of price transparency studies that many of you are probably familiar with. And then we put those studies along with other data sources, including Nashville Hospital cost tool data, or some of their data, into a tool to make it easier for employers to look at price transparency data. You can have all these giant machine readable files, and if I tried to download one of them on my computer, break my computer. So, I do appreciate everyone working to make these files usable, and get rid of dummy codes and just make the files. I would just like an extract summary. We don't have to, it's great to have all the millions of codes, but at the end of the day, we need to think about how to make it usable, maybe by clinical category. So you can have all the individual procedures if you want, which are great, because you could say, a total hip, total knee, left shoulder X-ray, right shoulder X-ray, whatever. But you can also aggregate all those X-rays and MRIs into something called images. And, and then the file just shrinks way down. And the way employers contract, and I want to talk about direct contracting, employers contract, they don't contract at the procedure level. They contract at the clinical category level. So they'll say, okay, I'm going to do a direct contract for orthopedics. with this provider group. And so I'm not going to send my hips here, my hip replacements there, my knee replacements there, and my wrists and my shoulder to all these different places. They're going to contract for orthopedics, contract for cardiovascular procedures, and so on. So that's what's happening in Indiana now. Our employers have been spending time going into the weeds, looking at things in clinical categories. We do have them organized in SAGE transparency by clinical categories. We hope that the tick files and MRF files become usable so then we can organize those in clinical categories and make those readily available for employers. But the thing that they're doing the most is, I would say, market strategies and policy strategies. So market strategies, I mentioned direct contracts directly to employers are not happy with a lot of the TPAs that they currently have partners which are the big TPAs. There's a lot of consolidation in the TPA market, not a lot of innovation happening because they don't have. And the second big thing I would say is we've seen a lot of on-site, near-site clinic movement because all of primary care, behavioral health, mental health providers have been gobbled up by the system, and not just the hospital system. It's like, United Health Group, right? Like they are just vertically integrated and they have insurance companies, PBMs, providers, blah, blah, blah. So we're seeing a lot of integration because, a lot of on-site, near-site clinics, because then you can not just provide more accessible, more affordable care, primary care, behavioral health, mental health, substance use disorder. You can also refer, again, based on, you can say, I'm going to send GI procedures here. I'm going to look at the best quality at the best price, and that's where people want to go. We need to read. Here's where what we're not doing well. We have contributed to the problem of medical debt for Americans. The idea of high deductible health plans was Reed and I have talked about this before. High deductible, she's smiling because I hope she agrees. High deductible health plans, that's what I'm on. Maybe many of you are on it as well. You have to pay thousands of dollars. You're paying for insurance, right, out of your paycheck every month for premiums just to have insurance. You need to have healthcare insurance in case you get hit by a car or a bus or a motorcade in my situation on the way over here. I couldn't believe how long it was. But you have to be really, you need it, right? Because you could get admitted, you could get to the emergency room. However, we have thousands of dollars of deductibles and co-insurance, right? Before your insurance even kicks in. So that's not really insurance, right? If you're paying thousands of dollars. So this high deductible health plan is not working. People don't have thousands of dollars in their bank accounts to pay for things. So they don't want to go to the doctor. They're like, oh my gosh, my last preventative care colonoscopy still cost me. So it's supposed to be free. Things get miscoded and whatnot. So I think employers need to revisit plan design and start thinking about identifying best quality at best price in like top tier. Middle tier would be middle quality, middle price, and worst quality at worst price. So that's what transparency is going to bring us. But then the benefit design has to get stacked right next to it to say zero out of pocket, best quality, best price. You could imagine all the providers in society, if they were $0 out of pocket for people, they would they're like, oh my God, my prices are too high. How do I get in a tier 1? I need to lower my prices. My quality stinks. I heard a provider yesterday explaining his 2-star rating by saying everyone else was cheating. And I was like, okay, well, we can have that discussion, or we could just say, those are real and we're going to use those and we can always improve upon things. But I do think employers need to be part of the solution, as do pharmaceutical manufacturers, PBMs, insurance companies.
Thank you. So I guess one of the things, we had talked about sort of the research, and research and data is everything in the sense of, what did we find? And we talked a little bit about it, but could you talk a little more about both what we found and maybe ongoing, efforts?
Thank you so much, Reid. And thank you, Stacy and Sabrina, for having me. What an honor. So let me just jump on what Corey mentioned, the recent report from Turquoise Health. So not only the top quintile price dropped, the average price dropped as well. And especially inpatient services, which are very expensive. So that's just a nutshell, in such the early evidence, I put that way, early evidence on whether the price transparency regulations worked. Price transparency regulation give us unprecedented insights on the data, on what's really going on in the commercial market. To give you 3 examples. First one, site-based payment. So our study published in JAMA Health Forum found in the same county, the hospital-based colonoscopy price is almost 50% higher than the same service in a physician practice. So that's in the same county. Before, we could not have such granular data. The second information is on the physician-owned hospital. You know, ACA has a ban on physician-owned hospital, right? So we look at the physician-owned hospital established before ACA. So in the same county where we have physician-owned hospital and non-physician-owned hospital, then we compare their price for the same service. Guess what? Physician-owned hospitals are 30% cheaper than the competing hospitals. Then number 3, if you look at the overall national market, we know the variation is pretty high, right, for commercial price. We know that. But do we really know in the same hospital with the same insurer? So I'm talking about the same pair, hospital insurer pair. Let's say Johns Hopkins with Blue Cross Blue Shield. Because Blue Cross Blue Shield can have multiple plans with Johns Hopkins, right? So we found within the same hospital insurance company pair, the variation can be 2 times. So let's say one plan pays $100. The other plan can pay $200. So that tells us many insurance companies are not doing their job, maybe intentionally, right? Because they can, on one hand, negotiate a very low price for one of their plans. On the other hand, twice that high for another plan, right? So that's the insight we could not get before. Most important, in my opinion, interesting is cash price. So the price regulation requires the disclosure of cash price. So who's paying that? Either uninsured patients or insured patients under high deductible plan choose to use cash price, right? Because it's cheaper because you're gonna pay anyway, dollar for dollar. So in the same hospital, for the same procedure, we found about half in the United States hospitals, their cash price is cheaper than their median commercial price. About 13% of hospitals actually have their cash price lower than any negotiated price. Again, this is a new evidence that nobody knew, right, before the price transparency. So that tells us many insurance companies are leaving money on the table. Am I right? So unilaterally determined cash price. Again, unilaterally determined by the hospital. It's cheaper than bilaterally negotiate the price. So that really asks us, ask a question, what are they doing, the insurance companies? And really build momentum for like more control on the patient side, right? Let's say maybe they have more HSA, let them save, let them benefit personally and directly. So these are just the tip of iceberg of the information provided by health price transparency. And I think this will have enormous implication on both policymaking as well as practice. Thank you so much.
All right, Anthony, you're going to be the cleanup batter here. So I'm interested in what you think the transparency dialogue in both, Washington and the states, how expansively we should be thinking about transparency.
No, I appreciate that. So first of all, just thank you to Georgetown for having me. I'm Anthony Wright. I'm as Reed said, the new executive director of Families USA, just 3 months yesterday. It's been quite a time to be in DC. And I come to this, Families USA is the longtime voice for healthcare consumers. I come to this work after a quarter century of doing this as a state consumer health advocates in New Jersey and for the last 2 decades in California. Having mentioned a lot of what I was doing in those last 2 decades in terms of a variety of efforts at transparency efforts. And my feeling there and my feeling in my new job is that now that I'm in DC, to use a DC phrase, we need to follow the money. If we're going to deal with healthcare costs in our healthcare system, we need to follow the money at every level, whether it is at the payer level with the insurers, or whether it's with regard to the various forms of providers, obviously hospitals, but also medical groups, also drug companies, also medical device manufacturers, also the range of services. And we need to have a better understanding of our costs. It drives consumers nuts that this is one of the few areas of public life where you cannot actually go and get like the price for a service that you need. And as was stated, there's some people that this might be insulated from it because they have a good plan, but there's an increasing number of people who are, there's a decreasing number of people, thankfully, who are uninsured, but an increasing number of people who are underinsured, who have these high deductible health plans or otherwise exposed because they have co-insurance or other forms that where these prices actually do matter to their very to their family budget, to whether they can make rent, whether they can pay for groceries. And so that's, if there's any mandate from this election, I think it was about an affordability agenda. And so I think that's why this is so important to move ahead with the reforms that are pending in Congress right now, including the Lower Cost, More Transparency Act, of which Families USA and many, many other consumer groups, including some here, are strong advocates for, because we need to have a better handle on this. I am not pretending that consumers can use those machine readable files, or even the much more simplified forms. This is not what normal people do. In order for something to be shoppable, it needs to be specific. It needs to be a schedule. It needs to be searchable. It's a fairly small.
Easy, right?
What?
It needs to be easy.
It needs to be easy, and there's a lot of things in healthcare that are not.
Yeah.
And so I'm not doing it, but I do think that there is a range of other audiences, whether it is payers, whether it's the press, whether it's policymakers, that do need this data to try to figure this out. Again, I come from Sacramento. I think by some accounts, the second largest purchaser of health services after the federal government is CalPERS. I actually have been in the building where there's literally a building full of people who are trying to make sense of the healthcare market to try to pay for services. And if they are having a hard time trying to buy the best quality, then what is hope for the average Joe, the average Jane? And so, but we do have those analysts. We do have those folks who can make sense and figure out some things. And so whether it is where there are specific market failures, where we can find out, hospital prices are not just high, but they're inflated and they're irrational in terms of how the broad variations between and among regions. We can find out that on prescription drugs, the element that's pending in Congress about having more data from the payers, the insurers, about what they pay in prescription drugs, and find out how much is actually in rebates. And because so much of what we've heard about the prescription drug prices, the prices are high, but we give it back in rebates. But then when we did that price transparency in California, there was reporting on the big number and there was reporting on the rebates, and it was like 10%, which 10%, I'll take a 10% coupon, but a 10% off of a high price is still a pretty damn high price. So that's the kind of stuff that we need as policymakers, as advocates, as analysts, to then take to try to address market failures, whether those solutions are ones to introduce more competition or regulated competitions, or more oversight and regulation. That's what we need to do. And so that's why I think it's great that there's pending right now, and we hope that there's movement literally in the next couple of weeks on whether it's on ownership, especially with the sort of massive changes that are going on under our feet with regard to how especially medical groups and doctors' offices are now being owned in lots of different ways, whether it's on PBMs, whether it's on billing location. We need to follow the money, and I think that it's not the end-all goal in itself, but it's a tool to dealing with the crisis that people are feeling with regard to affordability. We're talking about affordability about a lot of things now, but we've been screaming about healthcare affordability for literally years and decades, and we need to do something.
Thank you all. So I have one question before we open it up. and it's about quality. Okay. I mean, price transparency is great, but, very affordable bad care is still bad care. So I'm curious what you think, how transparency fits into all of this, and, jump in or.
So yeah, quality transparency is critical. We all want to have the best quality at the best price. No one's interested in going to a F-rated hospital that's cheap and come out dead. So, we are interested in the best quality at the best price. I just think it's critical, so we have quality transparency, price transparency. We've talked about ownership transparency. I think financial transparency of the hospital is really important too. A lot of them provide community benefit. And so we need to better understand how they're providing community benefit. And then some of them are claiming that their margins are low, profit margins are low, but they could be sitting on billions of dollars in assets that are on Wall Street or offshore or someplace else, and they're nonprofit hospitals. So I just think there's opportunities, definitely in quality, but how you define quality, patient clinical outcomes quality, 100%. But I think a quality of data and quality in ownership and quality, like just having good information all the way through is really
important. We published a study in JAMA last year. Johns Hopkins Hospital spent tens of millions of dollars a year on reporting quality. Guess what? Not useful. Because there's no consensus, right? It's just, you think about how great about money. Universal trust, right? Universal exchangeability. But there's no such a measure in quality that we can mandate for disclosure. So I think if we want to do some mandate, we should be careful because that can be counterproductive.
I just want to follow up on Gloria's comment. On the hospital and health system side, we really do need to understand a little bit more about how they're financed and their quality as well as a combination. So, states are coming to us saying, help us understand, like we have a hospital cost tool, full disclosure at NASHP, to try to help them really understand more about their cost. But there isn't quality associated with that cost tool right now. And I do think there needs to be both those parts of the equation. States are huge purchasers. So is the federal government, by the way. So in terms of state and play health plans and Medicaid, and they have been asking us, like, we actually want to think about centers of excellence. How do we work with our health plans to direct to those entities that are both efficient and high quality? And maybe it won't be the lowest price on the market in terms of negotiated rates, but the quality is there. So I really think that's an important piece, and how we translate that to both policymakers, but then also to consumers. I think consumer piece is really hard. And that has been a longstanding challenge across our health system. And so we'll have to work with Anthony and think about how we, and other consumer groups that are in the room, about how we do better. I work at the state policy level. We really are helping state policymakers understand this. They're having trouble with this. They have analysts and been working really hard to understand it. So then how do we even take a step below that and really think about consumers? And I think the federal government, the transparency laws is a great step, but we have a lot.
I mean, I just very quickly, we need to also do quality. It shouldn't be in the way of the price piece, but it is, at the end of the day, what we want is value for consumers, and that has to be both. I think the number one thing that I think astonishes consumers and is not fully well understood is that right now health prices have very little, if no correlation with the actual prices. That some people actually mistakenly believe that, like, oh, if you pay more, then you must be getting something more for it. That's not what the cost, including, let's say, for hospitals, is not correlated with the cost of that service, the quality of that service, the outcomes of that service. It's much more dependent on, because we have some initial data on the relative market power of a given payer or purchaser, given consolidation and other factors. So the incentives now are to get bigger, not to get better. We need to create those incentive structures, and that requires transparency of both the price and the quality level. That's a lot easier said than done, but it has to be the goal.
I think we're opening it up to questions.
I think they want you to grab a mic
Yeah, so
because it's
people
being
can hear
recorded.
us.
My apologies. I don't know. My own apologies. I'm so used to apologizing.
All right, I guess I'll start again. Eric Ellsworth, Consumers Checkbook. We do a lot on first-person kind of stuff with shopping. So one of the other areas that has become a lot of interest to us in consumers understanding prices is the coverage criteria that go into services. So, and that runs through a part of the insurers called the P&T committee. I'm wondering if you all know of any efforts to bring transparency to that area and what you think about it.
I'm all in favor of that transparency. I think you're right. I mean, my sense is that consumers, it's a black box. And often I would argue that there are financial incentives behind coverage rather than necessarily care incentives. But you talk to a lot of consumers and they assume if they get a denial, it's because actually, wasn't good care. Okay. So I think you're right, but I don't know of any efforts. And if you do, I'd be interested.
Yeah, so one idea that we have that we're trying to address some of that, it doesn't really quite get to, the Pharmacy and Therapeutics Committee, and I'm a pharmacist by background, so I could spend all day talking about how the incentives are misaligned to where the drugs get put on formulary and rebates. But I think there's an opportunity for, now I lost my thought. All my explanations. I'll find it. Go ahead.
Brett Jackson with the Economic Alliance for Michigan. My question is, prices are coming down on the top. How do we prevent prices from rising on the bottom? And I'll give you a quick story of how this is really happening. So Gloria's wonderful pioneering RAND studies, the second study came out, Michigan was at a 156%, both inpatient and outpatient prices above Medicare. The most recent study has the same inpatient and outpatient prices above Medicare is now 211%.
Mm-hmm.
The second study was released in 2019. The recent study was released in May of this year. So in a 5-year period, we've seen a 25% increase in prices. And if we look at the NASHB data, we know that the commercial break-even price pretty much through that whole time is 107%. So prices are going up. The cost of providing care is still relatively flat. So how do we prevent the bottom from coming up? Because Michigan hospitals are looking at Indiana and saying, we want what they have.
Yeah, and we're like, we want what you have. So there was an entire report that Chapin White did, Michigan versus Indiana on prices. Like, what's Michigan doing, versus like, why are we so high? So price transparency is great, but it's just foundational. Price transparency in and of itself is not going to fix anything. You just have to have it, and then you have to build on it. You have to use it for market power. You have to get in there, ban physician non-competes. You have to get in there and you have to really think about policy strategy. So everyone who thinks that price transparency alone is not the answer, is the answer alone, you're going to see, everyone can see each other's prices. They're like, hey, Anthem, you're paying them 500% of Medicare. Why aren't you paying me 500% of Medicare? So, they have to say, no, we're not paying you. We need to bring prices down. So in Indiana, we're really focused on trying to bring prices down. We have so many consolidated markets. It could be one hospital, not just in that whole county, and even surrounding counties, because it's so rural in certain markets. So what if they're 700% of Medicare? Okay, price transparency tells you they're 700% of Medicare. That's not helpful. That's not helpful, even if they have good quality or bad quality. So we are really looking closely at price ceilings. And it's like a terrible thing to say, maybe out loud, but what do? You have to say, we want competition. We want competition. We want free market. We want innovation. But at the same time, we're not going to allow you to price gouge people and charge them 800% of Medicare. Come on, right? There's got to be some ceiling under which innovation can happen. And that's only because we have such a consolidated market. Brett and I are friends back there from Michigan. And so that's what I would say, Brett, is really try to, and he is, he's very, very involved in policy and then very involved in the market. But you have to use price transparency, quality transparency, ownership transparency, financial transparency to create change.
To that point, if I'm not paying, myself, I do not care about transparency, right? Even if you give me the number, 50 versus 100, the same subject, I do not care. We do not care if we spend other people's money. That's why no matter how much my employer is trying to design the system, if I don't have skin in the game, I cannot personally directly benefit of it, I'm not gonna care. So that I think is the next step for us to really realize the price transparency potential is to let patients directly and personally benefit from lower price. That will mobilize the market to drive down the price. Thank you.
I just wanted to add quickly also, I also think you need the market reform tools that in addition to the price transparency. We've seen that. So the consumer can only do so much. And so using a tool to understand, we want our hospitals to be successful. We want our physicians to be successful. We need access to healthcare. But then understand in more detail, what is their break-even point? What are they actually, what does it cost to do business? And then understand how you can negotiate from there. Because without that piece, I think it's really hard to then decide, how do we really regulate and bring down?
I mean, I'll just very quickly, I do think that there's, with the tool of transparency, then you could figure out how to fix the market failure, whether it's through competition, through negotiation, or through regulation. And, so for example, we mentioned that there's 8 states that are setting cost growth target commissions to put some limited encouragement to quell the rate of growth beyond, how much people's paychecks go up. That's one mechanism. I believe in systems change that are bigger than the individual consumer, because I think that most consumers are not in a position to say no with regard to their healthcare. So they have no negotiating. If there's a financial incentive, they're still going to say yes to the healthcare that is important for them and their family. That is not a fair fight. A fair fight is if either the big payers or if we use the powers of government as a regulator, negotiator, or competitor to try to change the system to go toward high value, low cost care, and that's what we need.
Just two quick response. So number one, Maryland has a resetting, right? But our premium is definitely not the lowest. And second, the cash pricing, the patients or consumers who have the ability to say no and leave the market, leave the table, is really building the most powerful market force to reduce the price. That's why we're seeing the cash price, which is unilaterally determined by the hospital, facing those powerless consumers, can be lower than the commercial price in half of the market, whole national market. So I just say, don't underestimate the power of consumers. So in conjunction of the market reform and employer power, and as well as give consumers some leeway to play, to benefit, I think that's the right direction.
I'll just make one point though. Maryland has been incredibly successful in holding down the increase in costs.
The premiums,
but the health system. So sorry.
There's one.
Yeah, good one. So yeah, I'm just curious you guys' view of how impactful, we talked a little bit earlier about how impactful just price transparency is going to be. And the skepticism comes from, look, we know hospitals are consolidated. Government hasn't done anything. So there's things that the government could actually do that they don't do. But more information doesn't give a lot of confidence that they're going to do anything more in 5 or 10 years. I'm curious where you think about more direct market reforms that Guy kind of pointed to in terms of the consumer, and one maybe a third rail, but bringing back stop loss, right? I mean, 72% of employers with over 500 employees are self-insured. Yet you got to go and you either 10 grand for a healthy 35-year-old or financial ruin. And if we look at the average medical debts, 30 grand, 3-year payback, I'd rather pay for my own stuff and have a backstop that's 1 or 2 grand a year. So what are the ideas in terms of actually giving alternatives, not getting a cost transparency tool? Again, if you show me it's $3,000, $3,000 is what I have to pay for. But what are the real opportunities, or where do you think the interest in really going directly to the consumer to give?
Right, John? Yeah, great. Thank you. Great comments. Number one, let's think about extreme example. If I'm a Medicaid patient, so government sponsor a lot of money, right, to my insurance. remember, I cannot personally benefit from anything, from lower price or better health. Can I get more money? No way, right? If I'm not happy with this hospital, I want to go to a cheaper and better quality provider. Can I get any benefit from this? Not at all, right? I cannot personally and directly benefit from it. And also I'm constrained. Now change to another scenario. I got paid maybe $20,000 a year. Extreme example. If I have control of the money, then do you think I have more incentive to go to seek a better quality, lower price provider? Then keeps the remaining to myself, right? So that's how our current system does not allow patients to go around to benefit for themselves. So that's number one. The second point, stock loss is a great idea, but right now we are facing a lot of regulatory constraints preventing people from using that. So I think that's actually the one of the goals of the next administration. Thank you.
So I'm curious though, what about the payers, right? I mean, I thought we hired them to do all this for us. Maybe I'm wrong, I'm naive, but so, I mean, where do they come in?
So yeah, they haven't done a good job, right? And they haven't been they've also consolidated and now they're vertically integrated. And so now they own everything and they're self-dealing. And so we can't trust them. And so we need to have transparency, but just to answer your direct question, hopefully that answered your correct question is don't trust them. But your question, I think ICRAs are something that employers are looking at. It's like an HRA account. They just put money into an account per employee, and then the employee goes to the market and they go and buy what's best for them. Someone that's young and healthy and, single and maybe doesn't have kids, right? You're right. Like, why do they have the same plan that someone in their company who's inflating their premiums has, especially in those smaller companies? So that's an opportunity. It is more, I would say, free market in the sense that you put money in, there's good and bad. Okay. You put money in an account and then you go shop for care. Okay. But you're going to go shop for care and you don't have a lot of, the average, you might have a lot of understanding of healthcare and how to shop for an insurance plan, but a lot of people just go to the cheapest plan and then they'll realize when they need it, they have terrible coverage. And then that could spiral into medical debt. So I don't know that ICRAs are the solution, but we are seeing smaller employers in our market. And we stood up a law to give them a tax benefit. So it's better than having no insurance. It's better than being necessarily on Medicaid, but give their families some opportunity. Average family premiums are $25,000 a year, really ridiculous, right? So an employer could put in $25,000 in an ICRA and then just say and then you could go figure out what you want to do with those funds for your family. That's one idea.
I just want to say quickly that
we're the worst. We're the worst.
Just whether it's ICRAs or HACCP laws, I mean, there's lots of different proposals to do it, but I mean, some of this very much sounds like a shift of risk and cost to the consumer, which I think is the opposite of the affordability mandate that we were given by the voters. I think that would that just the complexity of it, but as described, much less the actual pain point and opportunity for medical, whatever you feel. There is real reasons to engage consumers. Don't get me wrong. Unions have been doing this a lot where they're negotiating for benefits, and they need the tools of transparency to say, look, in our plan, we're going to shift from this provider system to this provider system, and here membership is the reasons why we're doing it, for the reasons of quality and for costs and whatever, and that means that we could also negotiate you a better wage package. That money will come to you if you not. That's a way to do it. Covered California has standardized benefit plans where the plans are actually have standardized benefits, so it's head-to-head price competition, and that allows consumers to then choose the lowest cost plan if they're equal with regard to the provider network, but they know that the benefits are the same. So there's ways to structure competition and engage consumers. That is not about shifting the risk and cost of consumers, which again would be the opposite of what we're trying to do here at the end of the day.
Yeah, great. So just because
Okay,
this is
I'm really cutting you off.
Thank you. Sorry. So yeah, the same time we must engage consumers as well. Why? Because employers are inherently inefficient purchasers. Why? Two reasons. Number one, most employers have very dispersed labor force. You don't have meaningful market power at the local market, so you cannot negotiate a good price. That's number one. Number two, your benefit consultants and your TPAs are not aligned with you in their interest. The more spending it is, the better off they are. Therefore, we cannot rely only on the payers, on the employers to do this. It has to be a combination of the consumers and the employers together.
Okay, on that note, it is my job to be the bad guy as the MC. But I want to thank you all for joining us. I really want to thank our panel and Corey for this incredible conversation. I learned a lot. We'll have the recording up later. I think later today. We'll email it to you. You can share it with people who didn't come. And thank you so much for joining us.